Good afternoon. I'm Mark Hobb, Department Head of Food, Nutrition, Dietetics, and Health, and we welcome you to the 43rd Annual Grace Shugart Lecture entitled Nutrition Informatics, More Than Just Using Technology, presented by our honored guest, Mr. Martin Yadrick. Additionally, we are honored to have special guests in attendance. We have members of Grace Shugart's family, Jeff and Joanne Shugart. Jeff is the grandson of Grace. Thank you for coming. And Mary Ellen Shugart, who is Grace's daughter-in-law. Thank you, Mary Ellen. We also have Associate Deans from the College of Human Ecology in attendance, Dr. Michelle Toes and Dr. Shauna Jordan. Thank you. And we also have the Dean of the Graduate School, Dr. Carol Shanklin, who's also a faculty member in our department. We'd also like to recognize our current and emeriti faculty and staff. If you are a current or retired faculty or staff member, please stand to be recognized. Additionally, many thanks, I can't say how many thanks, to the Shugart Lecture Series Planning Committee. Drs. Mary Molt, Kevin Sauer, Amber Howells, Mrs. Erica Linshield, who can't be with us today, Mrs. Karen Rogers, and Mrs. Janet Finney. Please stand if you're present. Thank you. We're also grateful for the help of numerous students and staff members who volunteered their valuable time prior to today and today to make this event happen. Thank you, too. Before we highlight Mr. Yadrick's numerous accolades, I want to provide some background behind the importance of Grace Shugart and her lecture series. Grace Shugart served as the National President of the American Dietetics Association and was instrumental in helping develop our nation's first coordinated undergraduate dietetics program to educate students in a generalist program. The supervised practice program that Ms. Shugart championed continues today, nearly 50 years later. One of Ms. Shugart's passions was to provide high-quality, unique learning opportunities for students and faculty. A key means of accomplishing this was to invite leaders in the profession to campus to share their experiences and wisdom. Her passion is why we are here today. Mr. Martin Yadrick earned his bachelor's degree in food science and nutrition from Colorado State University, a master's in nutrition and dietetics from the University of Kansas, his MBA from the University of Missouri, Kansas City, and his master's degree in biomedical informatics from Oregon Health and Science University. Mr. Yadrick is currently the Director of Nutrition Informatics at Computrition. He is a past president of the Academy of Nutrition and Dietetics. He's also chaired the Political Action Committee and the Nutrition Informatics Committee of the Academy of Nutrition and Dietetics. Currently, he chairs the Academy of Nutrition and Dietetics Foundation, and Mr. Yadrick is a fellow of the Academy of Nutrition and Dietetics. He has given more than 200 media interviews and more than 100 presentations to peers and professionals. He has provided testimony to U.S. congressional committees and the National Academy of Medicine. It is a tremendous honor. It gives me great pleasure to introduce our 43rd Shugart Lecture Series presenter, Mr. Martin Yadrick.
Thank you. Thank you very much, Dr. Hobb, and I also want to thank Dr. Sauer, Dr. Molt, all the faculty and the students that I met with since I got here yesterday afternoon for all your wonderful hospitality. I made sure I wore purple this afternoon, and also to thank the Shugart family for continuing this legacy. So the topic that I chose is nutrition informatics, and my little slide advancer is not working. Okay. Flip that switch. Okay. So what is the first thing I'm going to do? Let me back up. There we go. We're going to define what this term is, because I ask dietitians all the time, do you know what nutrition informatics is, or students? And usually they're not really quite able to tell me. They know it has something to do with technology, but not the full definition, which we'll go over in just a second. We're going to talk about technology and nutrition informatics, how it's changing what we do as dietitians in this whole field of nutrition. And then what the Academy of Nutrition and Dietetics has been doing for the past 11 or so years to further this whole area of practice. And then finally, I was asked to just share some lessons learned and advice that you might want to get from an old dietitian like me. So here we go. So if you have ever done any of these things coming up on this slide, then you've used nutrition informatics. You've practiced nutrition informatics, like used a computer to get a nutrient analysis of a recipe or a menu or a patient's intake or anything like that, or accessed any online resource related to nutrition, such as the Academy's Nutrition Care Manual or its Evidence Analysis Library, or even a health-related website like WebMD, or many, many others. Or use the nutrition care process terminology, the standardized language for practicing nutrition in a patient's record. These are all aspects of nutrition informatics, and I'm sure all the students in this room have done at least one of those things. If not, all people in the room have at least accessed something related to health on a website, hopefully a credible one. If you Googled the term 13 years ago, you got nothing. I Googled it last week and I got 750,000 hits on that. So it's certainly a term that's becoming more and more familiar to people in the industry and to people that are just looking up the term for information. Even though the term and the use of it is fairly new, the concept is not new at all. And this is the study published in the ADA Journal in 1962, one of the first nutrition informatics related publications that, at least that I know of, that's about using computers for dietary studies. So it's been around a while. I have to give a lot of credit to two outstanding dietitians, Elaine Ayers and Lindsay Hoggle, who came to the board of directors of the Academy when I was on that board in 2006 and said, hey, this area of nutrition informatics needs to get on your radar. There's all these things going on related to standards development and coding things properly, that nutrition needs to be part of these efforts or we're going to be left behind. Elaine works for NIH, and Lindsay is now the Academy's director of nutrition informatics. Two powerhouses. And they published the first article in the journal related to nutrition informatics back in 2006. Now, there's been a lot of publications in this area since then, quite a few. So this is the definition of this term that was developed. We basically adapted one for biomedical informatics. It's more broad area. I'm not going to read this to you. You can read it, but if you really focus on the words in red, it's all about retrieving information, storing it, using it, to solve problems and make decisions. And it's standards and technology that makes this all possible. So that's what it is. But then we realized that if you asked a regular dietitian or Academy member to remember this, nobody could. I can't. So we came up with the Nutrition Informatics Committee of the Academy of Nutrition and Dietetics came up with this, more of an elevator speech, easy, intersection of information, nutrition, and technology. Anyone can remember that, and hopefully anyone can understand that. And I credit Nancy Collins, who's a PhD RD that was on our committee, and she has a website that used to be called RD411 that a lot of you may have accessed over the years. Great source of information. So most of you know that there are 6 formal areas of practice. Those of us in informatics really want the Academy to recognize informatics as its own separate area of practice. I think that might happen within the next 5 or 10 years. When the Academy first surveys its membership to see what area of practice people were in, there were in 2008, it was only 0.4% of people that were in the Academy that said they practiced exclusively in an informatics-related position. Well, last year, or the year before that, they surveyed again, and that number had grown to 3%. Now, 3% isn't a lot, but going from 0.4 to 3%, in about 6 years, you do the math, that's a huge increase, rapid increase. So here's how informatics touches all these different areas of nutrition and food-related practice. You can see the little examples up there. I mean, some of them are a lot more obvious than others, that I mentioned, like getting a nutrient analysis of a recipe or costing of a menu or something like that really is something that is done regularly in food service management. But all these other areas use informatics as well. So a lot of this interest in the importance of informatics started back when the Institute of Medicine, now called the National Academy of Medicine, released this report in 1999 called To Err is Human. And in that report, they recounted how up to 100,000 deaths a year could be related to medical mistakes, partially because of medical records being handwritten And, did that doctor write cc's of something, or does this mean something else, or was that dosage right? And they realized, the world realized that that wasn't going to suffice for going into the future. And all the people that are injured every year, tens of thousands of people that are injured, and even many who die because of these medical-related mistakes. And it isn't just back in '99 when that report was released in follow-up reports. This was in 2014. There was a Senate hearing about this. 1,000 preventable deaths a day related to medical errors. This was in the Washington Post just less than a year ago, that medical errors were the third highest cause of deaths in our country. So this is something that the government and the medical profession, the health professions, have taken very seriously. And part of this started with the adoption of electronic health records. You hardly go anywhere anymore, a doctor's office, where they aren't using an electronic health record. But you just see, if you just look at the graph, it wasn't that long ago where the percentage was really, really low. And so the government stepped in and incentivized hospitals and physicians' offices to develop the use of medical records. And they go in kicking and screaming. A lot of physicians will say, or healthcare professionals will say, oh, it takes me so long to do this, and I can't look up at the patient and do it. Well, for their safety and for all the other uses of data that's in an electronic health record, this is why this is so important. And you see the percentages going way up. And just a few years ago, the Department of Health and Human Services started certifying electronic health records as meeting certain standards and containing certain data in them. And then they developed something called meaningful use. And basically this is what needs to be in an electronic medical record and how can it be used to make it a meaningful use in terms of patient safety and other things related to patient health care. And so they came up with 3 stages of this implementation. I'm not going to go into a lot of details about it, but at each stage, certain information has to be in your doctor's office electronic medical record or your hospital's electronic medical record. And if they were early adopters, they got incentive money from CMS, Medicare, Medicaid, Centers for Medicare and Medicaid Services. By stage 3, which is, they keep pushing this in the future, but it'll be next year, if they don't have this information in there, they'll be penalized. In other words, they might not get reimbursed the 100% amount that they might get if they had the information in there. So this is an easy way to explain meaningful use that an informatics professor put up there. Here's a pumpkin, here's meaningful use of a pumpkin, okay? And then these are just a couple statements related to stage 2, which is what we're in right now. Things like when a physician orders a medication for you, it needs to be done electronically. How much anymore do you see them write out on a prescription pad and hand it to you? Also, they need to be able to provide lab values. I had some lab tests done a couple weeks ago at St. Luke's in Kansas City, and I get right on there online and I look up my labs, and then I send an email to my doctor, and then he emails me right back, and this is all through a secure website for that hospital. I'm sure many of you have seen this already, and that's a good thing. Well, not only because of having to do so for meaningful use requirements, but just for all the other benefits of having data in a structured form. Free text, you can only do so much with it. You could just copy it somewhere. Hello, have a nice day. Copy it over here. But if it's coded data about whether it's a diet order that's coded, or it's patients' diagnoses that are coded, or labs that are from a table, you can mine data. It's really revolutionized the way research is done. In the old days, to do research on patients' health records, you had to have someone from the medical records department looking through this huge stack of medical records, going to the page that had the information on it that was needed, and then recording it. Well, now, you just go into the medical records system and you say, I want a query for everyone that had this diagnosis between these months, so there was this age group or had this lab value with it. It's totally revolutionized that. But also in the upper left is clinical decision support. And if you're not familiar with that, a really good example of that is, remember a few years ago, the actor Dennis Quaid, his little newborn twins were accidentally given something like 1,000 times the proper dose of, I think, Coumadin that they were supposed to have for being infants, and they almost died. What clinical decision support does is it says to that healthcare practitioner that's entered that amount in the record, whoa, for this patient's weight, this dosage is way off. or this woman is pregnant, you can't give that medication to a pregnant woman. So it's helping the healthcare professional. Now, what happens, you hear about, is something called alert fatigue, where they get so sick of seeing this stuff pop up that they just click through it. But the purpose of it, the reason for it existing, is to capture errors like that, cut way down on medical errors. And so that is critical. And then in the center of all this is what we're trying to do with nutrition data, getting it coded more, the standardized language that the Academy's been developing since 2003, and other efforts that the Academy's doing that I'll talk about a little bit more. The other goal of all this stuff is a concept called the data follows the patient. Now, if I collapsed in 30 seconds, no one would probably know my medical history. I don't know if Kevin knows me enough about it, but you wouldn't know if I had diabetes or I had a heart condition or something like that. But if I had some sort of a national identifier on me, or maybe it's a chip in my brain or something, who knows, there'd be a way right away to say, okay, his records are at St. Luke's in Kansas City, and he has this, 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 and this. And that's the whole idea, that you shouldn't have to repeat everything you told Dr. A when you go to Dr. B. Oh, I'm allergic to this medication. You shouldn't ever have to do that, and that's the goal, that the data will always follow you. Now, a lot of this, the government's role in all this, started back in 2009. One of the first acts President Obama signed into law was called the American Recovery and Investment Act, also known as the Stimulus Act. This is what bailed out General Motors and tried to get the economy back on track. Well, a huge part of that act was something called HITECH, Health Information Technology for Economic and Clinical Health Act. And that has a lot of provisions in it related to the use of electronic health records and technology in general in healthcare. So one of the big goals of the HITECH Act is something called interoperability. And the best way I can illustrate this is if you think about going to the ATM. Now, you can go to the ATM here in Manhattan, or in Manhattan, New York, or in Riyadh, Saudi Arabia, and get money out because the banks talk to each other. Well, right now, electronic health records don't. They're competitors. Cerner, Epic, McKesson, all the different companies, Meditech, they don't, I don't know what their motives are, and I'm not saying one way or the other, but the bottom line is the health records don't talk to each other right now. So the language used, the programming, or whatever is done, the way records are structured, it's different from each one. Now, how did banks figure this out, 30 years ago or longer ago? I don't know, but that's the goal, is to make health records like the bank. Wherever you go, they'll have the information that they need to treat you properly. Now, a lot of people worry about this because of concerns about privacy, and those are very valid. You've heard about data breaches, whether it's at Target or wherever, or the hospital where somebody had the backup disk in their car and the car got broken into and that was stolen, and everyone, we've probably all gotten a letter about some sort of data breach. But there's things in place to protect against those breaches. The HIPAA, you probably all have heard of HIPAA and heard a lot about HIPAA, or had classes that talked about HIPAA, but it's designed to protect your privacy, and also the provisions of the HITECH Act. And this is a whole graduate course we could be talking about related to HIPAA, but just a few things about there. So PHI is protected health information. That's really what HIPAA covers. There's also something called individually identifiable health information. It's information that people could use to find out or narrow down to who might you be by knowing your zip code and your date of birth, for example. They could probably find out that that's you that has that dreaded disease. So there are certain safety measures in place to make sure that only the right person gets that information. And there's a concept called a covered entity. That's a healthcare provider, like a hospital or a doctor's office or a pharmacy or something like that, that has the legal right to access your protected health information. Also, your health plans, health insurance, they need to know because they're the ones that reimburse for treatment. And then there's also something called healthcare clearinghouses where a lot of this data is stored. So the covered entity, like a hospital or a doctor's office, is allowed to disclose this data for 3 reasons: to treat you, to get payment for what they did to treat you, and also for something called operations. like medical reviews or audits or legal-related things. So those are the three reasons, and in fact, the acronym TPO is used a lot to describe when a PHI can be released. There's also the idea of a business associate. So this is somebody like an electronic health record company who has access to protected health information. This is very much regulated by HIPAA laws, and the penalties for breaches are going up and up and up, and the enforcing starting this year is getting even stronger than it was before, and for very good reason. And business associate activities could be things like billing or data analysis, processing a claim, but even an employer like my employer, a food nutrition management software company that has patient protected health information like your diagnosis, your diet order, your date of birth, we are considered business associate. But even a shredding company, that protected health information that you put in the shredder bin or in the shredder itself rather than the regular trash can for good reason, not leaving it on the copy machine, is or could be a business associate. If the protected health information I've been talking about is not in there, then they're not considered to be a business associate. So just a real quick thing on there. So I've got a little video I want to show you, and I just have to start this up. This kind of for a little levity on this topic, but also kind of illustrates what a lot of people are concerned about related to protected health information. This happens to be from the ACLU. I'm really not trying to get political here. It's just kind of a funny video.
Pizza Palace. Is this Mr. Kelly?
Yes?
Thank you for calling again, sir. I show your national identification number as 610-204-999-8-45-54610. Is that correct?
Yes.
Thank you, Mr. Kelly. I see you live at 736 Montrose Court, but you're calling from your cell phone. Are you at home?
I'm just leaving work, but I'm...
Oh, we can deliver to Bob's Auto Supply.
No, I'm on my way home. How do you know all this stuff?
We just got wired into the system, sir.
Oh, well, I'd like to order a couple of your double meat special pizzas.
Sure thing. There'll be a new $20 charge for those, sir.
What do you mean?
Sir, the system shows me that your medical records indicate that you have high blood pressure and extremely high cholesterol. The total is $67 even.
$67?
Well, that includes the delivery surcharge of $15 to cover the added risk to our driver of traveling through an orange zone.
I live in an orange zone?
Now you do. Looks like there was another robbery on Montrose yesterday.
But I want double meat.
Well, I'm sure you can afford the $67 then. You just bought those tickets to Hawaii. They weren't cheap, eh? Oh, but I see you checked out the budget beach bum at the library last week.
I'll get the Sprout subs.
Good choice, sir. Gotta watch that waist if you're hitting the beach, eh? 42 inches. Wow.
That's how much?
Just between you and me, there's a $3 off coupon in this month's Total Men's Fitness magazine. Your wife Betty subscribes to that, right? Anyhow, clip that and it's $19.99 even. Whoa, looks like you maxed out on all your credit cards. Bring cash, okay?
Want to stop this from happening?
All right. So a little exaggerated there, but I think I love that one. It's hilarious. Let me just get back to my main slide here. Oops. All right. So one thing that goes along with this whole topic of protecting patient information is the idea of data being encrypted. Like when you swipe a credit card, the information is encrypted. People don't have access to that, or they're not supposed to have access to it. I spoke on this topic at a state dietetic association meeting a few years ago, and one of the dietitians who was in private practice came up afterward, and she said, well, you know, I always put the patient's diagnostic codes, when I bill them for my services, I put it in an email to them when I sent it back to them. And I said, you mean regular email? And she goes, yeah. I said, ooh, you better do something about that. Have you ever gotten a secure email message from a doctor's office or a bank or something where you have to log in a different way and create a login and password? That's what secure email is all about. So if you are a student that wants to be in private practice in dietetics, you've got to make sure that you're aware of all these health HIPAA-related laws and go on from there. I think there. So, I mean, the old days were this, with stacks of medical records and took forever to look for anything. Current day, there are still people that are resisting moving to electronic health records, but I love this one. Okay. And then if you think about other technology, that's the difference between, if you look on the left, that was a GPS back in 1981. It weighed 53 pounds and it cost $119,000, and that piece on the far left is really pretty scary looking. I think I've seen that at a doctor's office before. Whereas on the right, a little chip that weighs almost nothing, that's less than $5, or probably half of that now, that is what makes a GPS. You know, how many, well, I remember I travel a lot for my job, and we used to print out the directions from MapQuest, and you'd be driving, you'd be looking at this thing. It was nighttime, and as I get older, I have to make it larger and larger font. Well, now you just speak to Myrna on your phone, and she tells you where to go. So it's pretty cool. So all this stuff that used to be huge and big and whatever, cumbersome, now fits right in your pocket. And then this slide just has a few examples of how things that we can do on smartphones, whether it's the percentage of people that are now applying for a job right on their phone, or finding educational content, or looking up government services. One of the executive orders that President Obama did was that each government agency has to have 2 ways that people could access those services, whether it's National Park Service or Social Security Administration via a mobile device. So you see a lot more of that than you ever used to before. And then, of course, this slide illustrates all the changes that we've seen. Like, you know, I've got a friend in Australia that it used to cost me a fortune to speak to, and now we just do Skype. None of this would be a surprise to any of you. I mean, using Uber and Lyft these days is so much easier. So it's changed everything. Technology has helped this. Now, some of this stuff is really pretty far out. Huggies was working on something called TweetP that would send the mom or caregiver a tweet when the diaper was wet. Or so, Amber, you're going to look for some TweetP. And also with adult diapers, it would change color if they were dehydrated or had signs of a urinary tract infection. So, and this company, Pixie Scientific, is looking into all this stuff. I don't know if any of it is available on the market yet, but the last few years, every time I do this presentation, I keep looking to see what the latest thing is. So, you know, diapers that tweet you, pretty cool. And then there's more and more effort to help keep older people in their homes longer by using extra technology. And this is one that's at where I got my master's in informatics in Portland, Oregon, the Orchitect, they call it, Oregon Center for Aging and Technology, where the whole apartment is wired, okay? So they know when the person moves around there, they know when the door opens and closes, they know, they have a way to sense if the person falls. Now, some of that technology is a little imperfect. If they sit down in their armchair too quick, that might register as a fall. They also have a way to check their movement in the bed, just to make sure they are moving and not developing bed sores because of not moving. And I imagine there's going to be something that's going to look in the fridge and maybe do a quick nutrient analysis of what's in there, or if it's all not so great stuff. So this technology and a lot of the different things that are being tested and used in these experimental situations are really going to revolutionize this. Now, I mean, this day and age, there's wonderful places that people who retire can go live that are like country clubs now, the assisted living centers. But regardless, this technology is going to allow people to maybe not have their children worrying about them night and day. They can just look at a little monitor and see what's going on. And then there's also been some studies looking at the use of video games and how they help with memory. This was from a study that was done of 60 to 80-year-olds, and this video game is like they have to control this car and follow road signs and navigate around obstacles, and it actually did some work to help the attention-related areas of the brain. They helped their attention span, and the benefits from playing these video games actually lasted, in this study, they lasted 6 months. I mean, the attention functions were mirrored that of somebody in their 20s. So I don't know if that means all the old people like me need to go play more video games or not, but it's fascinating to see what some of this is showing us. So what is going on in the profession of nutrition, dietetics, food nutrition related to informatics? Well, a lot of it's been around for many, many years, using computers in food service management related activities, in health records, which I've been talking about a lot of this afternoon, and other things like telenutrition, telehealth and telenutrition are really starting to grow more and more and more. So you may not be seeing people in your office face to face, you may be seeing them on your computer screen to do nutrition counseling. Another thing that you see up there, I talked about data mining for research. Using mobile technologies, being able to collect data, to use mobile technologies to support the chronically ill at home, which I've been talking about, monitoring patients' vital signs, checking like check for asthma-related what am I trying to say, a spirometer, something to blow into, or checking blood sugar, a glucometer, where the information goes right to your doctor's office. You don't have to leave your home in the middle of winter and go to your doctor's office to have blood sugar checked or breathing checked, and things like that. So food service management, obviously a lot of things like printing, things like patient-specific tray tickets that are corrected for the patient's diet. This is kind of what I do in my day job. Nourishment, tube feeding labels, things like that, room service. Back-of-the-house functions that you do here at Kansas State in your use of software for this purpose, whether it's ordering, inventory control, menu and recipe costing and nutrient analysis, things like that. Being able to scan a room service kitchen ticket to see where it's at in the delivery process to make sure it's delivered on time, or to scan the patient's wristband to make sure, yes, this is the correct patient, and yes, they are still on that diet that corresponds with that tray. They haven't gone NPO yet, and other things like that. And then things like wireless temperature sensing. In the old days, there was a clipboard in the walk-in or the freezer where someone physically walked in and wrote down the temperature. Well, those days are not that much anymore, because these temperature gauges send informations, text messages or whatever, to you to tell you when something's out of normal range. Earlier, I mentioned the nutrition informatics surveys that have been conducted of Academy membership over the years since 2008. There's 3 of them. The results of the most recent one will be published this year, I believe, in the journal. But one of the other things that we ask people, besides what I talked about earlier about are you practicing in nutrition informatics, is do you have structured fields for entering nutrition-related data in the electronic health record? This is a little hard to see, but basically the highest percentage there had a combination of structured data and narrative or free text areas that we'll put in there. Very few, well at that time it was 26% had structured screens for using the nutrition care process. So to respond to that, about 4 or 5 years ago, the Academy created something called Andy. Now, Andy is not a person. It's a guy named Will Murphy created Andy, a dietitian that works for the Academy, but it is the Academy's health informatics infrastructure. And what this is it's a secure web portal where you can log patient information in de-identified format. In other words, you don't put the patient's name in there at all. You put the nutrition care process steps that you took, that you recorded when you saw that patient. And I think this slide is animated a little bit. It takes you through each of the nutrition care process steps, entering assessment data and parameters, nutrition-related diagnoses, those PES statements that those of you that have ever taken a clinical nutrition course learned about, problem etiology and signs and symptoms, recorded those there, intervention steps. And what Andy does is these nutrition care process matrices are behind the scenes, and they actually suggest certain interventions to you. You still pick what you want and put what you want in the record, but this is something that's available to any member of the Academy and any CDR credentialed practitioner. So if you are a registered dietitian, nutritionist, or a registered dietetic technician, you have free access to Andy. So I'm on one of the Academy committees that's trying to promote the use of Andy. We ask anyone that's in clinical practice, or when those of you that are going into clinical practice do so, to record at least 1 patient visit per week. And what happens when you record that and you save it is that writes that information to the Academy's outcomes registry, so that as time goes on, we'll have important patient-related information to see the results of our efforts, to show that we are getting positive outcomes from our intervention. Now, this information is de-identified. It's a little hard to see up there, but right here is when you save the entry on a patient, it creates a re-identification code. And now you, as a practitioner, have to have that code somewhere in a secure place so you know who that corresponds to. But there's nowhere in there. The most Andy asks you is, what country are you in and what state are you in? So that they can record some statistical stuff in that regard. But it is de-identified. So we really are trying to promote the use of this member benefit, or benefit to all credentialed practitioners. So keep that in mind, take a look at it. As a student, you can go on there and take a look at it and play around. There's a place where it says finalize entry. That means I am the practitioner and I did this intervention, and that's what writes to the Academy's outcomes registry. So don't be playing with that part of it. But you can still save data and come back to your patient by remembering the re-identification code. And there are also reports in there. There's a crosstab report where you can graph, here's the patient's weight over time, and here's the patient's blood sugar over time, or other parameters going up or down. You can tell it, I want to graph for these 5 patients or these 20 patients, I want to graph this lab parameter and this anthropometric measure, all sorts of things. You basically tell it what you want it to graph on the list. And there's other reports in there too. And I also mentioned telehealth. This is an area that's growing and growing, and I've been to several Dietetic Association, either state meetings or practice group meetings, where dietitians who are specializing in this area are giving updates. It's a very exciting, fast-growing area, and in the whole area of telehealth, state legislatures are starting to realize that you're not just going to be seeing people in your own state if you're doing this electronically. You're probably seeing people across state lines. So a lot of states have really liberalized their laws about who can practice in terms of telehealth and telenutrition across state lines. Certainly don't want to fail to also reiterate about the Academy's nutrition care process terminology, our standardized language, and the ENCPT subscriptions are available at a really inexpensive price to members of the Academy. And I don't need to go on any more about that. Certainly the evidence analysis library is a member benefit. How many of you have used this, ever looked up anything in the EAL? Okay, several of you, good, okay. It's an amazing member benefit, and the information in there grows all the time, so you can see what is the evidence related to X plus Y. Is there really evidence in there about that particular premise related to nutrition? So it's something that I encourage all of you to take a look at if you're a member of the Academy. There's also, now these next few things are just resources, the other resources that the Academy has related to nutrition informatics. One is just this online nutrition informatics community. And anyone who's an Academy member or student member can join this. There's about 1,200 people in there now. And the website, the URL for it is at the bottom. The name all started from the American Dietetic Association Nutrition Informatics Committee, but adanic.webauthor.com. All the Academy online communities are run by this company called WebAuthor. But it's just a place to post things like, oh, has anyone ever used this electronic health record? Or has anyone ever found some resources for talking on this topic? It's a great online community. It's available there. There's also, within the Food and Nutrition magazine that the Academy produces, there is a regular nutrition informatics blog, and they're always looking for guest bloggers if you're interested in this area of practice as you go further in your career. There's also hundreds of apps. I used to have a slide in this presentation about how many apps there are related to food, nutrition, and health. And the last time I looked, the last time the website that I went to for this was available was 22,000 different apps. 22,000 apps. Now the Academy has produced a bunch, several dozen of these apps, and then people that are nutrition informaticians, dietitians interested in nutrition informatics, are producing apps. About 2/3 of the apps on the screen pictured up here are from members who have developed them themselves. I do a talk each year in Los Angeles for dietetic interns on this topic, and at the end of one of my sessions, one of the students said she developed some apps, so probably some of you in the room have developed apps. And then there are also structured committees in the Academy related to this whole area, the Nutrition Informatics Committee, and then an offshoot of it called Interoperability and Standards. They're working with a group called HL7 who decides what information goes from electronic health records to software like lab software, pharmacy software, food and nutrition management software, and the format that it's been in. What the Academy's working with them on is establishing standardized diet orders, so you can't have a situation where one doc orders 2 grams sodium, one orders 2,000 milligrams sodium, and one orders low salt and one orders low sodium. They're trying to standardize that. They're still working on that. That's a huge project. And then at the bottom there, the most recent group is Consumer Health Informatics. This is how do you work with the consumer on issues like health literacy? Is the website you just developed able to be read by somebody with a 5th grade education? Is the app that you're developing easy to use? Is this information easily accessible by the average consumer and their average education level? That's what that whole consumer health informatics area is all about. It's, to me, one of the most exciting areas of the whole topic. And then there have been several articles in the Academy Journal about informatics. This one a few years ago was about careers in informatics. This one, more recently, I think 2012, was about competencies in informatics. They did what's called a Delphi study of practitioners and faculty out there saying, what kind of skills do you think people need to be considered to be at a beginner or novice level, and an intermediate level, and advanced and expert level? And the faculty in this room would know a lot more about Delphi studies than I do, but this was published related specifically to nutrition informatics. Then there's also a practice paper that was published a few years ago, and they're actually working on updating this information, and they may be also doing a position paper related to this. So our professional organization, those of you that belong to or will belong to the Academy of Nutrition and Dietetics, is doing a lot of stuff to have the information that we need. And then there's a couple educational opportunities for you. This first one, I'm not doing the sales spiel, but I am a co-faculty for this program. It's called 10 by 10. And what the name came from is in 2010, the people that really got informatics going decided that they needed to educate 10,000 people on health informatics by 2010. Well, I think they got there, but that name is kind of stuck. So it's an online course. The Academy is affiliated with one that has nutrition-related content. Now, it's not cheap at all, and those of you that are facing student loan payback, you don't even want to think about another expense like that. But those of you that are already credentialed practitioners, it does provide up to 54 continuing education units, which is like 2/3 of what you need in a 5-year period. But we're starting up a new course on April 26th. It's online with the optional attendance at an in-person session at FNC, the Academy's annual meeting in Chicago on October 21st. So that's my little spiel about that. But for you that are more budget-minded, this just became available. A group of us worked on a series of informatics-related CPE webinars. The Academy just released, I think in the last week, made this available. And if you're a member of the Academy, they're only $24 each. So, for 120 whatever bucks, you can get a really great introduction into several areas of informatics. So the resources are there, and information on that is in Eat Right Weekly if you're an Academy member. There are also a lot of other online related resources on all the topics I've talked about. Healthit.gov is probably one of the best sources for information in the broad area of health information technology, and they're updating the information there all the time. There are also a couple of great newsletters. This one I subscribe to, and there's an issue out every week, if not more frequently, called Moby Health News. It's all about mobile technology, and every single issue each week, or more frequently, has 5 or 6, 10 brand new things that are going on related to the use of mobile devices in health technology. And then another one is called Healthcare IT News. So a lot of this stuff is out there. It's free. All you have to do is go to the website and sign up if you're interested in this topic and get more information. So we invite you to join us in being a nerd, a nutrition informatics registered dietitian. And okay, so the final part of what I'm going to say to you today, as I was asked to do, is if you had any advice to give a younger version of you, or to all of you that are students, what would you say? And so here goes. Number one is knowing food service management is critical. As I said to many of the students yesterday and today, I started out as sort of a clinical snob. I didn't care about food service management as much. I picked an option within my undergraduate program that was clinically focused, so I only had to take one food service management class. And then I did my internship at KU Med Center, which was a clinical internship. But then when I started working for my company, even though my main focus is on the patient nutrition care side of our software, I really have been at a disadvantage for over 20 years because I didn't take a more generalist approach to dietetics in my undergraduate program or in my internship choice. So kudos to you. I know I'm standing here in the mecca of food service management, if not in the country, in the world, if not in the whole world, certainly in our country. And so I applaud you and the excellence that you show in everything that you do related to that topic here. Okay, so that is definitely my numero uno. Just as a volunteer, if you decide you want to be a leader in your state association or in the national, my advice, well, for anything in life is always follow through. Don't tell people you're going to do something and then not do it. Because then when it comes around for them to be looking for people to be in certain positions or be on a ballot for some role, they may not want to work with you because you didn't follow through. So that's that advice there. Don't be afraid to fail. You all know times that you've made mistakes and you've learned from them, and that's kind of what your mom and dad have always told you. Don't be afraid to make mistakes. But I'll tell you, I told the group yesterday, when I applied for internships, I didn't get in the first year, and they used to have this thing where they picked a certain number of people, then they had alternates, and I was an alternate, and I didn't get in. So I went to work for this stationery company doing customer service, working the 3 to midnight shift. That was really very exciting. The other thing I didn't mention is that I also applied to graduate school at 8 different universities, and I got 8 rejection letters, okay? So if I had, and then I reapplied for my internship, and I was an alternate again. I thought, oh, good Lord. And I thought, if I don't get into that, then that'll be the sign from above that I'm supposed to do something else. And then I got in, and then I think, I've had a lot of fun in my career, but I started out kind of rough. So don't let setbacks in life. And I've talked to some students who had some setbacks and had to reapply for this and that. Keep going with it. This one is critically important, and those of you from SDA I talked to yesterday, always stay science and evidence-based. It may be really popular to have certain opinions that are real popular in the media now that may be against things that are science-based in our field, in the fields of agriculture and nutrition. There's a lot of misinformation out there, and I even see some colleagues in my own profession jumping on that media popularity hype bandwagon. Don't do it. You'll hurt the profession, you'll hurt yourself as a professional and your own credibility and the credibility of our profession in the future. So keep that in mind. Always make sure that the information that you're sharing is based on science and evidence, and that you're believing, and that you're putting on social media. This last one, I don't know. Has nothing to do with dietetics necessarily, but man, you guys, save your money. You're going to need 7 figures, not counting the cents, to retire in comfort. Those of you that are younger, to retire in comfort. And I don't mean retire rich, I mean retire in comfort, so you're not at Decubitus Acres Long-Term Care Center when you're ready to retire. It's something that I didn't learn this from my parents. My parents grew up in the Depression, and I think they wanted to shield my sister and me from things like worrying about money, so I never really learned about budgeting. I thought when you get older, you could just buy whatever you want. And I honestly, I believe, and when I was about 30 years old, I had a dietitian at a clinical job that had sat down with me and say, you need to open an IRA. And I did. But I wish I would have started a lot sooner and contributed a lot more. And you can, when you get a job and you have a 401k, you can contribute $18,000 a year right now. And when you get to be 50, you can contribute $24,000 a year to that. I know I'm harping way too long on that topic, but that is really important. If someone said that to the 20-year-old me and I really understood it better, I'd probably retire in the next couple of years, but I'll probably be working 10 more years. So that's the end of it. I really am grateful for being invited to be part of this. I'm very honored to be part of this lecture series today and be your speaker. So thanks to everyone for inviting me. And there's my contact info.
Thank you. What a wonderful presentation. We do have a few minutes maybe for a few questions from the audience. We have microphones. If you'd please use those for the video audience. I will also take this time to mention if you are here for some CEUs, please see Dr. Hansen at the back on your way out to make sure you sign up on the sign-up sheet for those CEUs.
Don't be shy. Oh, good.
I wrote it down. I was wondering, do you think that clinical decision support, or ANDI, do you think that has an impact on the educational system for dietetics, maybe possibly relying too much on technology?
It's a good point. I mean, obviously, the clinical decision support is designed for patient safety, to make sure that mistakes are not made that are critically important. You still learn the information about why you need to do certain things that you do, or why people need to be on a certain kind of diet, or why you can't give them that certain food because it has an allergen that's a problem for them. I think it's just meant to be kind of a safety factor in there. I mean, Andy, the whole idea, Andy's sort of a different thing. It's designed to be a place to record intervention. See, one of the reasons why I think the dietetics profession has not gotten a lot of reimbursement, it's been a struggle to get reimbursement for our services, is that we haven't been able to show outcomes. And there's something called the U.S. Preventive Services Task Force that actually looks at all the body of evidence that's out there for certain interventions and actually gives it a grade of A, B, C, or whatever. And the higher the grade, the better the grade, the more likely you are to get reimbursed for your services. So, over the years, it's been certain things like diabetes care and renal care related to nutrition that have been able to be reimbursed. We're trying to get this expanded to things like obesity and everything else. So having outcomes data, the whole reason I'm mentioning this is Andy is a repository for your intervention that the Academy then will then analyze and say, well, look, we had 13,000 patients here seen for insulin-dependent diabetes or type 2 diabetes. And when the dietitians worked with them and they lost weight, their blood pressure went down, and we can see this information from all the data that's in there. So that's why Andy's around. So I don't know, sort of two different things, I think. Thanks. Carol.
Over the years, I've had the opportunity to work in 2 organizations with IT around our electronic health system and the nutrition component of it.
Yeah.
And do you have any words to the wise on how to be effective in doing that? Because they kept coming back and saying, well, we're just going to use the program that we purchased. And so both of those use text. We had only certain data points, like height, weight, certain labs.
Yeah.
But they didn't want to, at the time, it was before our language, they were not interested in doing any kind of programming for us because of the cost.
Oh.
Because anytime you want to adjust what you get in your package, then obviously there's developmental cost. So how do you advocate for yourself in your role as a dietitian, but for visibility and including nutrition so that it's core data that goes to everyone else?
Wow. Yeah, that's a hard one to answer. One of the things that the Academy is doing is mapping its standardized language to something called SNOMED-CT, which stands for Systematized Nomenclature of Medicine Clinical Terms, which is sort of an international electronic health record language. And once our terms are in there, I mean, that's going to be more universally used. So I think as more awareness increases about the standardization of our language. When we first started doing this stuff, the standardized language was still being developed. I mean, the assessment terms were, I think, the last thing to be put in there, so there really wasn't the whole package to go and present to like an electronic health records committee or something like that. I think that's a hard question to answer, but I think the task might be a lot easier now that the standardized language is a lot more mature and that it is being mapped to internationally recognized languages like SNOMED-CT and another one called LOINC. So I think we'll see. But you need a strong leader with seeing the big picture that's in there, saying nutrition-related parameters have to be part of that as well. And we can do so much more with coded data than free text data, which they'll certainly understand that part. Easy for me to say. Jill?
We have a student that is interested in going into this field. Do you have any recommendations on like classes to take or like experiences or anything like that to kind of boost their resume to move that direction?
Sure. Well, one great example is right here at Kansas State, the use of software in the food service management area. That's that whole area of informatics. If that is an area that they may want to go into to work for a company like my company or one of our competitors, that's great. Getting involved in like that online community that I showed you earlier, being part of that, you'll get some information from that. The newly released webinars, they aren't too expensive even for students. I don't remember if there's a student member price or not, but I know it's $24 for members and like 50-something for non-members. That's a great little introduction to it. And I suspect that, and the 10 by 10 I talked about is way too expensive for the average student unless you get a grant to do it. We did have some money from the foundation in the last few years of that course that assisted people, would pay like 1,000 of that 2,300. That helped a lot. But still, for a student, that's a lot of money. So I think the really just staying on the radar with that by logging on to the WebAuthor online community, maybe taking that course, the online webinars for CPE units, are ways to start. And then I think this is just going to keep growing. It's going to keep growing a lot. So those are a few ideas, I guess.
So if there are the more communication between the different programs that are like the Cerner and computrition, all of those together, if they became better at communicating with each other and had it so that it was able to cast a broader web, I guess, do you think that they would be able to use the information, or that you could let patients opt in to let people use their information anonymously for research, such as like people that have diabetes and doing studies to see how, like what kind of medication they're taking and how that has been lowering or...
Do you mean like as an individual practitioner being able to?
Or even just like someone who wants to do it on a broad, I don't know.
I mean, of course you'd have to deal with an institution's IRB, the Institutional Review Board. Is that what the I stands for? Which, makes sure that the patient data, the primary reason for that is patient data staying secure. So that's a big chunk of that. As far as data being available, I don't know what's going to be available to Academy members related to what Andy is doing. I think they're going to mine the data. You might be the one to suggest to them a research topic on, intake of X plus lab values of Y and end result of Z, suggesting that research to them. I don't know that it's going to be something that you could tap into individually because of all the privacy concerns. I don't know. Did I understand your question?
Oh, no, I just meant
Okay.
for research in general. Just like if there's a school or something that wants to research a certain topic and
Oh, yeah.
look at that kind of information, or just different institutes, like Stowers Institute or something.
Yeah, no, I think that's already going on right now. I mean, if they're accessing a facility's electronic health record system, then they go through the Institutional Review Board and make sure that they've indicated in their proposal that all the privacy-related things are the way they should be. I think a lot of that's going on right now to mine data in different research projects. Yeah, I think so.
Again, my experience has been years ago because I haven't been in a hospital setting for a number of years. But what I noted is that some of my colleagues who were clinicians went and got some IT training and then went to work for the IT department. And because they had the clinical background, they were very effective in what they did, and they just didn't work with food and nutrition. One of them worked with pharmacy and worked with other departments, the clinical discipline departments. So there's value in deciding, do I want to be a clinician of one kind or another, or do I want to be in food service systems, or do I want to be in the line, which I thoroughly enjoyed being the clinician working with my food service colleagues. And we were able to do some really fun things around what the menu had, but met nutrition parameters for one population was Meals on Wheels that had therapeutic diet requirements. So, at one point we needed a report to be, at the time, we needed to document to CMS and other regulators that we met the 24-hour rule for screening. So one of the IT staff members who had some clinical background, I don't remember in what area, it wasn't nutrition, because she knew, she designed a report that all I had to do go in at the end of the month was put in my date parameters and request the report, and out came my documentation by patient. And of course I didn't then I would cut off the line with the patient's name to give to the surveyor.
Sure.
But right there it showed, and I had my data on percentage of requirements and how long it took, and all of it.
There, it's at our fingertips.
But I had also worked with other IT members who came into it with IT expertise, but had not worked in a hospital before. So they didn't have that kind of background. So if this is an interest, develop it as you're working, so you have practitioner experience to bring to the output that you do with your IT.
Yeah, thanks, Carol. A lot of times when I talk on this topic, I have 4 or 5 slides just highlighting people in dietetics who have gone into IT-related positions. Now, I don't want to lose anybody out of dietetics ever, but they're interested in technology and it's a skill for them, and they're getting some really great positions that have some nice salaries with them too in the IT-related positions. Whether it's a food nutrition-related IT position, which a multi-site hospital system might have, or just a strictly IT position that may deal sometimes with nutrition-related parameters like diet order, standardization, and things like that. So there are a lot of opportunities out there. People end up sometimes in places that they never expected they'd end up when they first decide to major in dietetics because of all these opportunities that are out there now. And I just saw a colleague sent me a little website that a link to related to salaries, and it was apples and oranges because it wasn't the same survey that did it, but comparing the two, the median salaries for people in nutrition informatics was about $3,000 a year higher than other professions. So who knows what we'll find out about that when the Department of Labor is really looking at that down the road, but it's exciting to see the growth.
Thank you once again, Mr. Yadrick, for your presentation for the 43rd year. Again next year for the 44th Shugart Lecture Series. Thank you.